Right. And where's our chat? There we go. Okay. So last week we stopped here and we're getting into elasticity and compliance. And the way the notes are and like some of the stuff, it's kind of wrong. So we're going to clarify it. Elasticity is the want of the lungs to snap back. So elasticity really plays a role in breathing out. It wants to recoil, right? Rubber band wants to recoil. Compliance is how much it will give. So when we're breathing in, we want a compliant lung so we can take a big deep breath in. Then we want elasticity in that to make it rebound and push the air out. So when you talk about like emphysema, they lose elasticity, but they gain compliance. So they're hyperinflated. It's big old barrel chest. In pulmonary fibrosis, it's the opposite. There's high elasticity and lack of compliance. So these are like, they call them pink puffers, kind of lean, breathing very shallow. Okay. Asbestos, for example, causes like fibrosis. Heavy metals can cause fibrosis. Emphysema, typically you're going to see smoking is the root cause. There are some rare like genetic disorders where they have like collagen issues, stuff like that, and you can see emphysema in them. But for the most part, smoking is the number one causation. All right. So COPD is chronic obstructive pulmonary disease. So there's lots of things that fall under this, like emphysema, um, asthma falls under there. So there's an issue pushing air out. So the issue in typical like emphysema is the loss of elasticity. They can't push the air out. In asthma, it's because the bronchioles tightening down. They can't push the air out. It's the obstruction. All right. Once people develop emphysema, that's it. Once you develop true COPD, that's it. There's no coming back from it. Now it's just dealing with symptoms and trying to mitigate it as much as possible. So they're not getting air in, they're not getting air out. So what do? We give them drugs to try and open up the airways and maximize that. We give them drugs that prevents this production of mucus because that's going to affect diffusion. We start giving them supplemental oxygen. Okay, very, very tough disease over time. Cystic fibrosis? Cystic fibrosis is like they create very mucousy like secretions in the lungs and it blocks diffusion. But that's due to a defective chloride protein. So they can't pump chloride in and so water can't follow. So in that situation, they just can't diffuse. So they get these mucus plugs in there that need to be broken up. They actually wear they used to just beat their back. Now they wear like these vests that'll vibrate and help break them up so they can get them out. Why? I don't know why they use the word fibrosis in there because it's not fibrotic. Mm-mm. No, I'm not sure. Not that I recall. All right. No problem, Erica. Whoops, jumped. So asthma, it's at the bronchial, it tightens down, and they can't push the air out. So this is why you get the wheezing. That's the air traveling through there. Lots of things can be triggers for asthma. Severity of asthma is different in people. Um, like chronic asthma is, I think it was, you will get woken up 3 or 4 times a month and you're considered chronic, like from the asthma, or if you have a certain amount of events throughout the month and have to use your albuterol. It doesn't take much to truly be classified as asthmatic. All right. Same thing, they produce excess mucus, they can't diffuse the air, the airway closes, and so they use drugs like albuterol, which is a beta 2 agonist that helps open up the lung airways. Sympathomimetic drugs, this would be like you're getting into like epinephrine, stuff like that. Typically, we start with albuterol. There are other inhaled like steroids that can be used for patients, but the number one, albuterol. Okay. Severity of asthma, like I said, can be real severe. I remember we had a girl when a classmate of mine when I was like in fourth grade or something. I remember they cut a field trip short and sent her in an ambulance to the hospital because she had such bad asthma. Um, she wouldn't respond to like albuterol, stuff like that. So they have to use stronger medications. That's really where you start to see those sympathomimetic drugs. Go through these terms. You should be familiar with all of them. Okay. Uh, we kind of cover this in lab too. And breathing rate, it's 12 to 20, 12 to 18 is normal eupenia. Tachypnea, so tachy is fast, pnea, breathing, so fast breathing. Bradypnea, slow breathing. Dyspnea, difficulty breathing. Hyperventilation and hypoventilation. So this is now at the cellular level. We're saying how much CO2 and O2 is on hemoglobin, okay? And how much CO2 is like in the plasma. When a patient breathes too fast, so that's tachypnea. The breathing rate is really fast. But the depth of the breath matters. Like if a patient's breathing very fast but very shallow, just they're not exchanging CO2 necessarily, and they're not bringing in oxygen because they're just in that conduction zone, right? So they may be hypoventilating even though they're right? So the depth of the breath matters. So when a patient is breathing in deep, they could be breathing slow. They could have a bradypnea, but they're breathing so deep that they're breathing out too much CO2 and they are fully saturated with oxygen. The other thing you're breathing out is hydrogen ion. So when you're hyperventilating, you're getting rid of hydrogen ion, you're getting rid of CO2, you can go into a alkalotic state. Okay, so the respiratory system is the causation of this alkalosis. It can be response to other issues in the body. So we'll learn that the kidney and uh, for the most part, the kidney and the lungs are controlling a lot of our pH balance, right? And then the hypoventilation, we see that where they are not breathing enough out. So the shallow breaths or breathing really, really slows down. Then we can start to see that hypoventilation. So they enter an acidosis. The pH has dropped too much and they are acidotic. Lung volumes, you guys go through this in lab, but I like to use the chart on the next slide or the slide after to run through these, okay? So anatomical dead space, there is an area where we don't use, all right? So we can't through the conducting zone, okay? We can't use that volume. So they say it's about 150 mLs. It's going to differ person to person. All these volumes will differ person to person. So I'm going to use this chart and then we'll go back and look at the words. So tidal volume, that's normal breath. The amount that we can't use is about 150. We can't use that area. Okay. So sorry. So I'm talking two different things. Tidal volume is how much is going in and out of your mouth, essentially, into your lungs. Of that, about 150 isn't usable. Down here, there is a portion of the lungs we cannot use. That's residual volume. You just cannot deflate your lungs all the way. Say I'm breathing normal, and then I breathe out, and then I all the way out. That's expiratory reserve volume. Say I'm breathing normal, and then I breathe in max amount, so at the end of a normal breath, and then all the way in, that's inspiratory reserve volume. The difference between the two, or the total between the two, that's vital capacity. That's how much I can move my lungs from max in to max out. That's a total air I can move, vital capacity. All right. And then the functional residual, that's how much I can breathe out. Or sorry, I can't breathe all of that out. That is below that is below a normal breath. If we take away expiratory reserve volume, so how much I can breathe out, that's residual volume. That's you can't collapse your lungs beyond that. Okay? So what do we do with this information? One, we look at are they male or female? Because that can alter things. Chest cavity is different size, stuff like that. Oops. So we know that tidal volume is about 500. That's normal breath. So the first thing they can ask you is how much are they breathing per minute? So we take how many breaths per minute with how much they're breathing in regular. We come up with 6,000 mLs or 6 liters. Don't get bitten by this. Okay, when you're doing like your homework test questions, do not get bitten by this. Remember your units. They may give you something in mLs and ask in liters. Then we look at that's what's going in their mouth. But is that what's making it to their lungs? It is not. So we know in this situation, we need to subtract for anatomical dead space. So we take that 500, we subtract the 1500. So, or sorry, 150, not 1500. So there's tidal volume, which would be 500 minus dead airspace, and then we multiply that out. And in reality, the 6 liters that they're taking in, only 4.2 is making it to the alveolus, is actually making it to the lungs and we can use. Okay? So you need to know those differences. We went through these, okay? Vital capacity, all of that. And then last is FEV1. FEV1 is your ability to push out 75 to 85% of your total lung volume that you've breathed in of your vital capacity in 1 second. If the number is higher than 85%, they have a fibrosis. Because of that high elasticity, they're just shooting it all out. If it is lower than that 75%, they have some type of COPD, like emphysema, right? So this is where, like, if you have asthma or something like that, they'll do like the breathing and have you measure, and they're really like push, breathe out as fast as you can. They're measuring these capacities and seeing if they're normal for your size. Okay? Control of breathing. So we have a couple areas in the brain we talk about. So there's 2 medullary centers. So we have the dorsal respiratory, so the DRG, that's controlling rate through the diaphragm. And then VRG, the ventral, that is for forced breathing to help encourage the use of the external intercostal muscles, stuff like that. So when you're working out, you need to take big, deep breaths. All right, and then in the pons, the big thing with the pons here, your book says CO2 and hydrogen ion. It's really hydrogen ion, and it is most definitely not O2. Most definitely not O2. The amount of saturation on hemoglobin is astronomically high. The body responds to CO2 and hydrogen ion. When are we going to see an increase in CO2 and hydrogen ion? When there's heavy cellular respiration, when the muscle is working, when the body is doing things. It's burning through that ATP. Then it's going to generate ATP, and we'll see lots of hydrogen ion, lots of CO2. Hydrogen ion crosses like the the blood-brain barrier very easily, and so it's very sensitive to that. But also the carotid sinus, aorta, they're picking up on CO2 as well through chemoreceptors. We're sensing a chemical, so these are chemoreceptors. So remember, hydrogen ion, CO2, that's what it's responding to. We will maintain oxygen level if you're a healthy individual. If you're a healthy individual, when you're exercising, your breathing rate, your heart rate will increase, and your lungs are diffusing properly, you should maintain saturation levels of oxygen. The only thing that's going to bump up CO2, hydrogen ion. Dalton's law, this is just that the total pressure of a gas is equal to the partial pressures. Basically, can we do addition? That's really what it's getting at. So, when we look at the body and we look at the air around us. We rely on gradients. We rely on that there is more oxygen outside of me so that it can diffuse into me. We rely on that there's less CO2 outside of me so it can leave me. All right? So when we've gone through the tissue and we're coming back to the lungs, so we're coming from right ventricle, these are the values we see. We see there is low oxygen and high CO2. Once we go through the lungs, we saturate, and they say 100, 105 millimeters of mercury for O2, and we desaturate the CO2 out of us. It diffuses out of us. So if we alter that, if there's more CO2 outside of me, it can't leave me. If there's less oxygen outside of me, it can't come into me. Okay, so we rely on those pressures. So external respiration, that's what's happening in your lungs. We're pulling oxygen in through the alveoli onto the hemoglobin, and we're getting rid of CO2 from really primarily from plasma and into the air inside our alveolus and then out. Okay? So external respiration, lungs. So that's what they're showing here. This is coming from right ventricle, low O2, high CO2. The lungs should have high oxygen, low CO2, and it'll diffuse. It readily diffuses for these reasons here. There's lots of space, lots of surface area, capillaries to alveoli, okay? It's very thin. It's 4 cell membranes and a basement membrane, because we have the 2 cell membranes of the alveolus here, the 2 cell membranes of the epithelium of the capillary, and then basement membrane between the two, right? And then the partial pressures, that's just referencing the difference, the gradients, okay? Internal respiration is at the tissue. So now I'm like in my foot, and what we'll see is O2 will drop a little bit because these cells that are lining the vessels are taking some of it. But we won't really see CO2 jump up yet. When we get here, the same thing. This tissue has been doing work, so it has used up the O2, and it has created CO2 through cellular respiration. So we see a diffusion and then on the backside here, we should see O2 has dropped, CO2 has increased, and we're going to go back to heart, then back to lungs, and do it all over again. Okay, so remember, internal respiration is at the tissue level. Think your foot, right? So here, these are just images of what we were talking about with the different pressures, what we should see at the lungs, what we should see at the tissues. This is the 2 images together. All right, so O2 requires hemoglobin. To transport O2 around, it requires hemoglobin. So you'll see a high percentage is attached to hemoglobin. You start losing hemoglobin, it's the same thing as drowning, suffocating. So when patients have low hemoglobin, that's a big deal, all right? 3% dissolved in the bloodstream, minimal. But the big guy, oxyhemoglobin, when he's attached. Oxygen saturation curve. So all this is saying, as we're over here, this is at the lungs. As we go through the tissue, it drops. But what you'll see is the numbers don't line up. So when they talk about at 100% saturation or close to 100%, we're like at 100 millimeters of mercury on O2 saturation. And we can drop a little bit and we start to swoop. But there's still a lot of oxygen on here. You're looking, we're in the 90s, okay? But we're dropping here. And that's why when you talk about, what's affecting breathing rate, all of that, oxygen isn't the big player. CO2 and hydrogen ion are, because the saturation levels are high. So when someone dips, I want to say it's below 92%, they're typically on supplementary oxygen. That's usually like when you're talking on COPD patients, that's all they've dipped. It's not much. Anyone else, you normal person, you walk in, you get your saturation checked, your hemoglobin saturation, and you'll be like 98, 99, 100. How fast is this? Patients will have the little pulse oximeter on them. So it's sensing the oxygen through your skin, through the nail bed. And they'll be at like 98. You just tell them take a big old deep breath. Boom, 100. Okay? It's like instantaneous. That's how fast it's circulating through us. I learned something interesting. You always like, they talk about the pulse ox, they put it on the finger. But what happens if they have like painted nails? It doesn't see it. It has a hard time reading it. What if their toes are painted? You put it on their ear. Their ear is thin enough to see it through there. Pretty handy. All right, so top of the curve, pretty flat because saturation is so high. As we pass by the tissue, it deoxygenates. As it deoxygenates, you see the hemoglobin numbers start to drop. Like when they're talking about this, they're measuring using catheters. In a normal person, you would never see this like on their finger. You never should see this. If you see this, they are passed out, stuff like that. That is not typical. But what they're saying is if we pass through all the tissue and we went into the inferior vena cava and we start measuring, this is what we should see. We should see that drop. These they're talking about like active tissues, long marathon runners, they can extract more. Yeah, but they're also going to oxygenate better than you and I, right? They really shouldn't see drops. Okay, we'll go with it. All right. So remember, this is lungs. This is tissue. When we say hemoglobin saturation is high, that means there's a lot of oxygen on the hemoglobin. It's in the lungs or right after the lungs. Oxygen saturation is low. We're talking about like inferior vena cava. We've passed through the tissue. We've extracted as much oxygen as we can, and we're going to send it back to be reoxygenated. Oxygen will leach onto myoglobin, and there's other globins in the tissue, will leach to it as it's needed. So if a tissue isn't like highly active, it's not going to be taking oxygen. The extraction rate depends on the tissue. You talk about like in your heart actually extracts a majority of it. So if they look at like coronary arteries versus like coronary sinus, the extraction rate is astronomical because that muscle is working high intensity. The amount of blood coming through it or to feed it isn't tons, so it really pulls it off of there. Okay, and that's why it's so susceptible to lack of oxygen. We damage the heart tissue very, very rapidly for that reason. So O2 saturation, that's using a pulse oximeter, and it's measuring how much oxygen is on the hemoglobin. He's got 99. He's good. 82 heart rate. So what shifts it? When you say right shift, that means tissue's working. So any time tissue is working, think about it. If I'm exercising, temperature will increase. If I'm exercising, I'm going to produce more carbon dioxide. If I'm exercising, I'm using ATP like wildfire. I'm going through cellular respiration. I'm producing hydrogen ion. So acidity occurs. Left shift, think sleeping, cold. Okay, we'll see left shift. Right shift, working. Left shift, dormant. Okay, so that's what they're showing here. On the top here, we're showing temperature. Look, normal is the blue. He's working. Temperature's increased. He's cold. Less demand. Okay. Here, same thing with pH. Normal in the blue. He's working. pH decreases. He's rest and digest. pH increases. Okay. So remember, right shift, active. Left shift, inactive. That's the easiest way to learn that. Carbon monoxide poisoning, it irreversibly binds. It's something like an affinity of 600 times that for hemoglobin compared to oxygen. So once carbon monoxide binds, that's it. Where do we find carbon monoxide? What produces carbon monoxide? Why? Huh? Cars? Gas? The burning of anything. So when you burn fuel in your car, it's producing carbon monoxide. You burn wood, charcoal, it's producing carbon monoxide. You smoke cigarettes, it produces carbon monoxide. It binds irreversibly to the or to the hemoglobin. How do you know someone has carbon monoxide poisoning? How do you know? By looking at someone they have carbon monoxide poisoning. Anyone know? Any guesses? No guesses. Are they blue? That's what you would think. You would think their like lips and stuff would be blue. They're actually cherry pink. They're bright red lips. That is a sign, and it's due to the dilation of the vessels because everything's freaking out and not getting oxygen. It doesn't constrict. Um, so yeah, that's a sign. You will hear about carbon monoxide poisoning all the time, especially in the winter here. You hear about people. I remember there was a case on the news that a family had carbon monoxide poisoning. They had pulled their grill into the house to heat the house. And so they were using just fire in the middle of their house, producing carbon monoxide, and they all had poisoning. You hear about people, they have their cars backed in their garage and they run them and it leaks into the house and they get carbon monoxide poisoning over time. Um, in Florida, we always get it with the hurricanes because people put the generators in the garage, stuff like that. And that's what exposes them to it. When patients smoke, because of the carbon monoxide on the hemoglobin, they tend to have polycythemia, increased viscosity. So there's the increased heart risk, and then the delayed wound healing because they're not getting oxygen to the tissue. It can't create ATP. It can't repair. So I remember my surgeon, whenever before surgery, he would, well, that's on the questionnaire. Do you smoke? No. And every single patient, he would request to see their carbon monoxide saturation levels because it's good, like defense ammo. Like a patient comes in and they're having poor wound healing. Oh, it's the surgery. No, no, no. It's because you smoke. Okay. So they can use that, to protect themselves essentially. So CO2, it's different. We said oxygen, 97% travels on your hemoglobin. Here, it's only 23%, very low. Some is dissolved, but the majority is bicarbonate. So we'll see this HCO3, that's bicarbonate. That's what we use as the buffer system in our bloodstream. We produce it from CO2. We can change the levels according to our needs. Okay, so that's how we bind, we'll see like hydrogen ion as well. So you guys remember seeing this, right? This part of the equation right here, really you guys saw kind of this guy in the stomach, parietal cells. That's how we were creating the hydrogen ion for our acid in our stomach. This is the bicarb buffer system. It can go either way. So what happens, we produce CO2, we bind it with water, we have carbonic acid. Then what we can do is release the hydrogen ion and create bicarb. To hold the reaction, we shift chloride out of our red blood cells. So here, this is a good image for it. There's the tissue. We generate CO2, comes in, we run the reaction. We take the hydrogen and we bind it to hemoglobin, and then we shift chloride out and it holds it as bicarb. When we get to the lungs, we reverse it. We pump in the chloride, we release hydrogen ion out in our breath, and then we reverse, we create CO2, we breathe it out. Go across the lungs, okay? So if you reverse the arrows and you put lungs here, that's what happens when we get there. So we reverse the process. So make sure you guys learn the equation. You need to understand it. And we'll talk about it again in the kidneys. We do the same thing with bicarb, creating hydrogen ion, urinate it out. So that's how we create the acidity in our urine to help protect us from organisms traveling up the urethra. So this is just the breakdown showing like how oxygen, it's traveling with hemoglobin, carbon dioxide, all of that, and they have it in the images here as well. Okay? So, jumping back to hyperventilation, hypoventilation. If a patient is breathing too fast and getting rid of too much CO2, they start to have what's called respiratory alkalosis. The body will react and wants to maintain its pH. So what does it do? You stop urinating out as much hydrogen ion. It can try to correct it. It compensates for it. Hypoventilation, so this respiratory acidosis, they start urinating out more hydrogen ion to try and get rid of it. What we'll see with this compensation system, if it's something wrong metabolically with the body, the lungs react instantly. You start breathing faster or slower to compensate for it. Just like diabetic ketoacidosis, DKA. These patients will come in and because they're breaking down fat rapidly, they're creating ketones. The ketones are acidic. They have a metabolic acidity going on. So what do they come in when they're unconscious? Just breathing, okay? That's Cosmol's sign. That is a sign that they have DKA. You don't even have to go beyond that to know they have DKA, basically. They are just hyperventilating in response to this acidosis in their system, trying to create respiratory alkalosis, okay? Hypercapnia, this just means too much CO2. Well, if there's too much CO2, the body is active, right shift, we should see more hydrogen ion. We should see they're acidotic. Because of this, we should see breathing speed up. If I'm running, I'm working, I'm creating more CO2, I'm creating more hydrogen ion, what should my body respond? I should start breathing faster. I should start breathing deeper to get rid of the CO2 so that my tissue is okay. And vice versa, hypocapnia. If I am asleep, I am not moving, there'll be low CO2 because my metabolic rate is very low at that point. We should see pH increase, hydrogen ion decrease. So what do we notice when we're breathing at night? It's slow. I'm hypoventilating. I'm trying to hold that CO2 in that I need. Man. Oh, I'm going to show you guys something. We don't cover it in here other than what we just did, but this is great. You will use this and it will help make your life easier. So let me, I need to screen share to show it to you guys. Share content. Just do screen share. Okay. So here, when a patient comes in and we have to figure out what's going on with them, is the body responding appropriately? What we do is we take an ABG, arterial blood gas sample. We look at the pH. If they're below 7.4, they're acidotic. If they're above 7.4, they're alkalotic. The next thing you look at, what's their bicarb level? What's their carbon dioxide saturation level? If the bicarb is low, just not good. That's metabolic. Then we look at respiratory. Is the CO2 low as well? Then the respiratory system is compensating. So this would be a situation where DKA, that's what's going to happen. They're going to come in, the bicarb's low because it's binding up all the hydrogen ion trying to. So there's no hydrogen or there's no bicarb available anymore. So what does the body do? They start trying to breathe fast to blow off the hydrogen ion. Well, simultaneously, they're breathing out CO2. Okay. If a patient takes, let's see, if a patient takes a stupid amount of Tums, right, it can happen. So that you'll see alkalotic. So what happens? We'll see bicarb is huge. They'll have a very high bicarb. So it's a metabolic alkalosis. What we'll see is their breathing rate will slow down and you'll see that CO2 increase to try and bring it back to normal. So it's a great chart to learn. I really encourage you guys to learn it. Take a screenshot of it, whatever you need. Um, it'll help you in the future. Okay, it helps make sense of these acid-base disorders. All right. Man, we still have a lot of time. Let's see. I guess we can just move forward. Right, today's the 11th. Yeah, we can move into urinary. Why not? Let's move into urinary. Oops. So like path phys, that chart I was showing, you got to know. Because like we give, in that situation, we give them examples and we talk about do they have compensation of the system, what's failing, that kind of thing. So that is something if you decide to go take path phys with me, you got to learn it. We'll just get our feet wet with urinary. All right. When we look at the urinary system, no problem. Wait, let me pull my chat so I can see in case you guys type anything. All right. So when we look at urinary system, we have 2 kidneys, 2 ureters, 1 bladder, 1 urethra, right? Some people have 1 kidney. It happens. You don't even know it. The reason being your kidney, but the functional unit inside of it is the nephron. We have excess. So what happens is one could pick up the slack and you never know it. You do like urine samples, stuff like that. You never catch it until they do imaging, and then they'll see you're missing a kidney. It happened to one of my students. Lady was like in her 40s, and we covered this topic, and like a couple weeks later, she comes to me. She's like, "You won't believe what happened." What? She's like, "I had to get some imaging, and they accidental discovery. I've got 1 kidney. Never knew. Lived her whole life like that." Right? That's why you can donate a kidney. Your other one will pick up the slack, right? As we age, kidney function declines. And diabetes is huge here. So the number one causation of death for diabetics is end-stage renal disease. It is an inevitable if they do not control aggressively glucose levels. What happens? Glucose is a solute. It moves into the tissue, water follows, destroys the tissue. So it destroys the kidneys. So that's why we start metformin for pre-diabetes. Like I got close. I told my doctor, just give me metformin. It's just not worth it. What they discovered is they were finding microalbuminuria, small amounts of albumin, protein in the urine. There's 2 things we're always going to say you never, ever, ever, ever should find in the urine: cells and protein. If we see cells and protein, the lining of the kidney, the functional like filtration membrane of the kidney is damaged. That's it. Never ever should we see either in the urine. Now cells, we can see like when you talk about like people have like kidney stones, stuff like that, and as it damages that ureter or the urethra, we can see blood. We'll see cells. They get infections, we can see white blood cells. But as a norm coming through the kidney, we should never, ever, ever see protein or cells. There's another one that lives on the border here, and that's glucose. We really should never ever see glucose in the urine. If you're a diabetic, we're going to see glucose in the urine. Okay? There's just too much. The kidney can't pull it back into your bloodstream because there's just way too much, and that's why we're seeing it in the urine. All right? You don't see glucose in the urine unless you are a diabetic. That's the only time you're going to see that. So, kidneys function is to work 24 hours a day, 7 days a week, 365 days a year, or out of the year. Okay. The whole job is filtration and waste control. That's like primary. Secondary, making causing your body to make red blood cells, activating vitamin D. But primary, I would say, it's your filtration system. It has to get rid of waste. So potassium, too much potassium, we're in trouble. Heart will dysfunction. Too little potassium, heart will dysfunction. So it regulates how much potassium is coming in and out of the body, or staying in the body, I should say. Urea, when we break down proteins, whether it's from diet or breaking down our personal protein for nutrition, for generating glucose or energy, we process it in the liver and it enters into the bloodstream and it leaves through the kidneys as urea. So that's why we measure BUN, blood urea nitrogen level. It is an indicator of functionality of the kidneys, how well the kidneys are doing, as well as creatinine. When patients aren't clearing creatinine properly, and we see the high levels, then we know either the muscle is being attacked and breaking down or the kidneys aren't functioning well. Okay. So like when my vancomycin is like a big gun antibiotic. It rips on the kidneys. It will destroy kidneys very easily. So big part of what my wife always did when she worked in the ICU is monitoring vanc levels and then looking at creatinine. And so they always have to order creatinine level checks. And she would lose her mind when she'll order it and like it doesn't get pulled. The blood doesn't get pulled. The creatinine test doesn't get done. So now she's shooting in the dark on how much drug she has to give the patient. She could hurt their kidneys, or she may not be treating enough to deal with the organism. So it sounds silly, but it really could affect the patient. Okay, so when blood orders are ordered, you want them done immediately. There's a reason we're doing that. The other problem too is like the drug starts falling off. So if they're waiting for that creatinine and they miss a dose, well, now we're going to dip below how much we need to treat. And when you got to redose them, bring them back, it's sketchy. Okay, so it's something to keep an eye on in the future. pH control, we urinate out hydrogen ion or we'll hold on to it. And then EPO, erythropoietin. So when the kidneys are very susceptible to oxygen deprivation. If oxygen drops too low, they get damaged very quickly. It's usually the first organ to go when we have, shock, stuff like that. Usually the first to be affected. They can go into acute kidney failure and then they can bounce back. But it typically could lead to chronic kidney failure and they have to be on dialysis. So it releases EPO. EPO goes to the bone marrow and stimulates the stem cells in there to produce red blood cells so that we have that carrying capacity of oxygen. EPO is a drug that we also produce. So when patients they're on dialysis, they'll be getting EPO. It's the same drug that Lance Armstrong got caught using, the cyclist. He got caught using it because they can test the blood and they see the synthetic drug in there, and that's how they caught him. He's doing it so he could have more carrying capacity. If there's more carrying capacity, more stamina, less fatigue chance. So his saturation levels will maintain longer. And then he got smart about it because they're testing it. And so what did he do? He turned around and he would take his blood out in the off season, store it, and then right before an event, pump it back into himself. So he would have a temporary polycythemia, more carrying capacity, more stamina. And so when they test his blood, there's no EPO in there. Smart. Someone ratted him out, obviously, because he did get caught. So that's blood doping. That's what he was doing. But you see like teams in general do it. Teams will go in the off season, they go up to like Colorado to train. The reason they're doing that is there's low oxygen at higher altitude. Because there's lower oxygen, the kidneys start to become stressed. They release EPO, so they make more red blood cells. So when they come back to like Atlanta here and the Falcons play, they have more stamina to still lose, right? High altitudes, yeah. Mm-hmm. A lot of athletes do it. They'll go the high mountain areas, stuff like that, to increase that production. So companies started producing these masks that you wear when you're working out to try and do this. It's not going to work. it takes about 2 weeks of that exposure, constant exposure, to stimulate the production of EPO. It's not like I do a workout for 30 minutes wearing this mask and it's going to do something for me. It doesn't do anything. Right? Activation of vitamin D. So we absorb it through our skin. We need to activate it. The kidneys play that role. If once again, if they're on end stage or like on dialysis due to end stage renal disease, we will give them vitamin D as well. You'd be surprised how many people are deficient on vitamin D. It's almost everyone. It really is. Especially women are more susceptible because the makeup has SPF protection in it. And so like face and stuff isn't getting exposed. They're not absorbing as much vitamin D. But yeah, it's huh? From the sun. Yeah. Because yeah, really all you need is sun. But you also absorb it from like diet. So certain things like milk has vitamin D added to it because it helps with calcium absorption in the gut. So they add it in there as well to get more calcium into you. And then blood pressure regulation. So we're going to talk about this fancy system, the JGA, the juxtaglomerular apparatus. So we'll talk about that and Renin, his effect. Okay. And then the other thing I didn't speak about was uric acid. So uric acid is due to the breakdown of DNA and RNA. We produce it. We produce a certain amount, but then when you eat things like a steak, you produce more. So people with gout, they have an issue with uric acid. And so there's too much, it causes joint destruction. So they avoid, like they shouldn't eat red meat, stuff like that. Usually it attacks like the big toe first, very painful. But it destroys the joints over time if they keep on having flare-ups. I saw a guy one time, patient, he came in, he was all distorted from the destruction. And he had what are called tophi. Tophi are like these growths that they get from gout on the joints. And I mean, they were like that tall. The dude couldn't walk. He couldn't move his body. He was just completely contorted. And he would like shuffle. That's as good as it got. But a wild case there. So kidney, once it's lower than the other, the retroperitoneal. There's actually another crazy situation called horseshoe kidney. It's another accidental finding. They're connected when they were forming. And they get stuck on the, I believe, superior mesenteric artery. They get stuck as they're ascending up. Embryologically. We don't do anything about it. Completely normal function, everything. It's pretty wild. As far as covering the kidney, we have the renal capsule. So this helps prevent spread of infection. Then we have renal fat and then renal fascia on the most outer. So deepest renal capsule. That's what's stuck to it. Fat is needed for padding because of retroperitoneal. They actually will whack the back of your chest cavity, right? Abdominal cavity. Yeah, abdominal cavity. Having a moment there, okay? And then the fascia is for attachment. So it's stiff. Anorexic patients will actually get dysfunctional kidney function, because that renal fat is gone, and actually they are getting like contusions on the kidney. You also see it when you talk about like people like boxers. That's why they go for that. It's such a sensitive area because it's retroperitoneal, and they try and hit it because it's just incredibly painful after that. But yeah, they can damage their kidneys as well. All right. So macroscopic looking at the kidney, we have the cortex on the outer edge, medulla, center. We're going to see that there are lobes with these medullary pyramids in there. And then papilla, that's where we're starting to release urine into the minor calyx, and then major calyx and out the renal pelvis. Okay, so when we look, a minor calyx, so that's where we're collecting urine from one pyramid. Major calyces, that's where minors are all combining and the urine is traveling out of there. And then the hilum, just like in the lungs, the hilum, that's where we're having ureters exit, renal arteries enter, renal veins exit, and nerves enter. So this is cortex. That outer edge right here, that's all cortex. The inner area here is medulla. So this is all medulla in here. This is the pyramid, and the tip of the pyramid is the minor calyce. Minor calyce, when they combine, this is now major calyces. Once we exit the renal pelvis here, that's ureter. Okay. So renal arteries, they deliver a quarter of our cardiac output to your kidneys every minute. That's how sensitive these guys are to blood flow. The nephron itself, the functional unit itself, gets supply from surrounding like vessels, and then also from the filtrate that we create, which does not have cells in it, but it has plasma, and we saw there's a little bit of oxygen in that plasma fluid, the filtrate, so it gets oxygenation from there too. So the second you cut this guy, it's a big problem. Kidneys freak out, right? As far as flow through there, arterial and venous, they're pretty darn close. There's like one little difference, okay? Sympathetic fibers control this. The reason being they're controlling a vessel coming in so they can tighten it down if need be. So when we're running, fear, sympathetic kicks in. I don't want to create filtrate. I don't want to create urine. I don't have time to stop. I need to run. So that's why sympathetic controls it. So here, you guys can run through this, but they're showing all the different vessels and how and we talk about how we flow through them. I believe on the next slide. Here you go. So go through this. Really, our focus is going to be inside the box here. That's really the functional portion of kidneys. The afferent arterial, this is what's controlled by the sympathetic. Okay? What we're going to do is let blood flow through. It's going to go through this like the glomerulus, which is kind of think like a yarn ball. If you took a ball of yarn and you have the two ends of it, the afferent is the one coming in, yarn ball is glomerulus, and then efferent is what's exiting. What we're going to do is create a positive pressure in there and push into the nephron. We're going to filter out the blood. So we're just constantly filtering our blood. All right? And we're doing it by controlling really the afferent arterial. If we open it up, we can filter more. If we close it down tight, we don't filter as much. We don't produce as much urine. Okay? Same thing on the back side. If I open it up, I remove that pressure. I don't filter as much. If I tighten down the efferent arterial, I filter more. I increase pressure, I filter more. Lisinopril, ACE inhibitor, we're going to talk about that with the renin-angiotensin system, but really lisinopril, that drug, works on the afferent arterial. It dilates it. It's not a diuretic, okay? Diuretics are going to work on the nephron, and we'll talk about that, like getting rid of water out of the body. This is just increasing GFR, glomerular filtration rate, all right, by dilating this. We're going to talk about all that, all right? Ureters, so they're flexible. They're retroperitoneal. That's what's attaching kidney to bladder, and there's no sphincters in there. What they do have is, here's bladder wall. There's ureter coming in. When the bladder fills up, it squishes it shut. So it closes it that way. And the reason being, so like things can't swim up and get into the kidneys. And it will also affects like GFR and all of that because we're going to create more pressure inside the kidneys. And so we shouldn't produce as much urine, all that good stuff. Some people, it is defective. They have what is called VUR, vesical urethral reflux. And they actually, urine flows back up in here and it destroys the kidneys. They do surgically correct this. It was pretty neat. I got to sit in grand rounds at Emory, and that's where they developed the technique to fix it, which is pretty cool. The doctor that developed it was talking about it. So pretty neat. But yeah, they developed what's called hydronephrosis. The kidney all just bulges out. It's destroyed by the water, the urine flowing backwards and just creating a high pressure. All right, so ureters, they have mucosa. That's that transitional epithelium you guys look at like in AP1. no submucosa. It's just a tube for transferring fluid. And then muscularis, longitudinal, circular, it reverses on us here. It was always inner circular, outer longitudinal. Now it's inner longitudinal, outer circular. Keep that in mind when you look at it in lab. And then adventitia because it's retroperitoneal. So here we're looking down the ureter. There's that transitional epithelium. And then we have our longitudinal and then circular on the outer layers. Bladder, also retroperitoneal, also transitional epithelium. Remember that lets you change shape, right, as it expands. Detrusor muscle. So this is what is actually going to be triggered and contracted to make us urinate. So push the urine out of us. And then adventitia since it's retroperitoneal. The trigone area. So this is where, I believe we have an image right here. The two ureters come in and the urethra leaves. So it creates a triangle. The reason we talk about this is in the female, they are high risk for chronic UTIs. It has to do with urethra length. That's really what it comes down to. Because of the length of the urethra, females get UTIs. Males rarely get UTIs. It is not common. So really the reason is it's a short pathway for the bacteria to get up. And then what happens sometimes is the trigone gets colonized. It gets colonized, and so they'll get treated, and then UTI comes back. They get treated, and UTI comes back, and they keep on doing this. So what they do, believe if memory serves right, it's like a 1-month antibiotic they do, and that can help clear it. They got to take it for an extended period of time, and they clear it. Right? Really, older males have higher risks. Diabetics for males have higher risk of UTI, and then if they're taking certain drugs like was it Januvia, I think? They always advertise it on TV. It's a drug that blocks your ability to reabsorb glucose. So they start peeing it out. And because they pee it out, it feeds the bacteria. They actually have high risk of penile necrosis because of it. And not a nice drug. Because all that sugar coming out, they get nasty infections and can actually damage tissue. Not recommended. Yeah. But yeah, a buddy of mine's a urologist. I always share this story because it's just so glorious. It's disgusting. So he gets called down to the ER to consult a patient, 16-year-old male, recurrent UTIs. And they're like, what the heck's going on here? We checked him out. Everything's normal. Trying to figure it out. So they start kind of pushing on him a little bit. Well, he confesses. Him and his girlfriend, one of their parents is a nurse. They stole a catheter from her, and they were self-cathing each other for fun. He was shoving a catheter up his urethra for fun. And because they're reusing it, it's dirty. He was getting UTIs from it. Yeah. Reason number 47 why you shouldn't have kids. Stuff like that. All right. So as far as urethra goes, transitional epithelium near the bladder, and then stratified squamous because it's exiting the body. You may see pseudo-stratified in there as well throughout it. So female urethra, very, very short. Male has 3 portions. The prostatic, that's where it's passing through the prostate. Males have a prostate. Membranous urethra, and then spongy urethra. So we're going to see the membranous is what's involved in erections, and then spongy urethra is surrounding the urethra directly so that things can still pass through. Okay, and I'm going to stop there. So we made a good little dent into it so far. All right. Enjoy the rest of your day. May see some of you, may not see some of you later.